Yes. Good evening, everybody.
Good evening, sir.
Yes, Gauri is presenting.
Yes, sir.
Okay.
I start speaking presentation.
She can start presenting. Anybody wants to answer or tell anything can. As usual, I asked you, you can post it in the chat box, or you can unmute yourself and ask any clarifications. Okay. Okay, Dr. Gauri, we'll start.
Yes, sir. Is my screen visible, sir?
Yes, it is.
Yes. Demographic details. Mr.
Yeah.
Shiva, 20 years old male. He's a student from Poneri. He belongs to lower middle class. He came with the chief complaints of multiple tortuous swelling in the left lower limb since 5 years.
Okay. 20-year-old student
Yes, sir.
presenting with varicose.
Yes, sir.
Looks very unusual. Okay. What is the best? We'll stop 1 second here.
Yes, sir.
What is the best way of putting the presenting complaints in a varicose veins?
For long duration.
Yes. So all along we have been telling that the presenting complaint should be in as far as patient's own words, right? Next slide, please. Yes. So some people tell it is dilated, tortuous veins, varicosities. All those are technical terms or semi-technical terms. Okay. So I usually ask my students to put it as the patient gives the complaint. Okay. என்ன சொல்லுவாங்க patient?
Swelling இருக்குன்னு சொல்லுவாங்க.
கால்ல அசிங்கமா நரம்பு சுத்தினதுன்னுவாங்க. That will be most commonly the terminology given out by the patient. ஓகேவா? அதை அப்படியே லிட்டரா நாம டிரான்ஸ்லேட் பண்ணுவோம். ஓகே, அசிங்கமான என்ன? அன்சைக்லி, பார்க்க பிடிக்கலன்னு அர்த்தம். அன்சைக்லி. அக்லின்னா அது ரொம்ப எக்ஸ்ட்ரீம் டேர்மா இருக்கும். அன்சைக்லி மீன்ஸ் இட் இஸ் நாட் பிளசன்ட் டு லுக் அட். ஓகே. ப்ராமினன்ட் வெயின்ஸ் நல்லா தெரியுது, அவ்வளவுதான். ஓகேவா? ஸோ ஐ யூஸ்வலி ask my students to present it like that. Presenting with complaints of unsightly prominent veins in the right lower limb or right leg for the past 5 years. Okay. So this is just a suggestion. I think it's a better term. You can use it. Okay. So I usually present it like that. So 25 years old, so and so comes to the hospital with presenting complaints of unsightly prominent veins in the left leg for the past 5 years. Okay, right. Yes, is it only one complaint or more than one complaint, ma?
Only one complaint, sir.
Okay, proceed.
History of presenting illness. Patient was apparently normal back, after which he noticed multiple swellings in his left lower limb. The tortuous swelling was on left foot in front of the ankle, upper part of inner aspect of the leg, inner aspect of the left thigh just above the knee. It was initially small in size and gradually progressed to the present size.
Your voice is not very clear, Gauri. You can improve your voice.
Yes, sir.
Either connectivity or proximity to the system or your mic, something is not very receptive. Yes. Yeah.
Sir, is it audible now better?
Yes. Somewhat clear. Be a bit louder. Yes. Okay.
Yes, they increase in size on standing or walking and also by the end of the day, and decrease on lying down.
Okay.
It is associated with intermittent pain in the left leg, dull aching type, which aggravates on prolonged standing or working and relieves on lying down.
Okay. Right. So it's intermittent pain. Okay.
Yes, sir.
It is dull aching. Very good. and it is aggravated on prolonged standing, on working, release on lying down. Okay. Anything else you want to tell about the pain?
No, sir.
Go ahead.
Yes, sir. No history of night cramps, swelling of legs, pigmentation, itching. No history of non-healing wound in
Okay,
the
we will
lower.
stop a bit.
Yes, sir.
So, vascular complaints in a limb can either be venous or arterial.
Yes, sir.
From your elaboration of the pain, how do you differentiate that at this stage it's a venous pain due to venous problem and not due to arterial problem? What is the peculiarity or the nature of pain in venous pain versus arterial pain mainly? Can you tell me? Classically.
I'm not sure, sir.
A venous pain by history can most often be elicited. The patient tells his pain is intermittent and becomes severe towards the end of the day. That is a phrase or sentence you should observe. Okay, va? So it will be dull aching present throughout the day, but it will become severe in intensity and become more felt towards the end of the day. Okay, that is typical of venous pain. Whereas arterial pain, the pain occurs on exertion, relieved on rest. Occurs on exertion, relieved on rest. That's it. And towards the end of the day, if the pain is more severely felt, it is more likely to be venous pain. These are one of the important questions which they will ask you. Okay.
Yes,
How do you differentiate between a venous pathology pain and an arterial pathology pain? Okay. Right.
Yes, sir.
Proceed.
I say no history of night cramps, swelling of legs, no history of pigmentation, itching, non-healing wound in the lower limb, no history of breathlessness, cough, hemoptysis, no history of fever, prolonged immobilization, no history of trauma, abdominal pain or distension, no history of chronic constipation, dialysis, no history of previous surgery for varicose vein.
Quickly tell me the implication of each of this. First two you leave, omit away. Okay. Night cramps, swelling of legs, pigmentation, all are associated with venous pain. From third on, you tell why you want to mention this.
Sir, non-healing wound in the lower limb, it's a complication of varicose vein. Ulceration may occur.
Okay. So it is due to chronic venous insufficiency. Okay.
Yes, sir.
Non-healing ulcer presence in a varicose vein is indicative of this terminology, right? Chronic venous insufficiency. Right. Next one.
No history of fever is to rule out thrombophlebitis.
Okay. Before
Then
that.
prolonged immobilization
No, you said breathlessness, cough, hemoptysis.
that is a complication of varicose vein.
What is that? When do you get breathlessness, cough, hemoptysis?
Due to pulmonary edema.
Yes, pulmonary embolism. Very good. DVT. See, the prolonged varicosities can cause deep vein thrombosis, which gets dislodged sometimes and goes and get deposited in the lungs, causing pulmonary embolism. You'll have to tell immediately. Okay, va? Varicose veins, a patient complains of discomfort, breathlessness, cough, hemoptysis. You should immediately think of pulmonary embolism. Okay. Fever, your prolonged immobilization.
That is also to rule out DVT, sir. Prolonged hospitalization and all will cause DVT.
Okay.
Then history of trauma, the venous valve will get damaged because of trauma. That we can rule out, sir.
Okay.
Then abdominal pain and distension, any mass in the abdomen and all will decrease the venous return to the heart.
Be specific. What type of abdominal swellings or tumors can cause?
It's a retroperitoneal mass, pelvic mass, and
In male, in female, you should tell. Okay.
yes, sir.
In in
In
females, commonly
uh, ovarian cysts,
midline
sir.
midline swelling can arise from what structure in a female? Midline structure என்னமா இருக்கு? Single structure in females.
Uterus.
Uterine fibroids. Okay.
Fibroids.
Big fibroids, midline swellings, they can cause bilateral varicosities sometimes. Unilateral varicosities by left-sided or right-sided adnexal mass, ovarian tumor, which can impinge upon one iliac vein on one side, iliac, and cause unilateral varicosities. So when we ask a question, you should be telling all these things. Okay. In both genders, retroperitoneal sarcoma. Yes, Jemima is asking pregnancy. Yes, pregnancy also is one of the most important, very common causes of varicosities. But most often it is reversible, and a few cases the valves become irreparably damaged, and they will lead on to permanent varicosities. But temporary varicosities will be there. Jemima is right. So gender-wise, if I ask you, you should say gender-wise. In both sexes, it could be retroperitoneal tumor or lymphomas, okay, and big lymphadenopathy in the forking of the iliac veins, IVC. All the in female gender, especially, you should have midline swellings from uterine, laterally from adnexa, ovarian tumor, and any other bowel pathology can happen in both sexes. Okay, immediately you should have an anatomical understanding of what can cause such problems in each gender. All right, ma? Okay.
Yes, sir.
Right, next.
Then chronic constipation.
Yes.
I don't know the reason, sir. Why?
Okay. It can lead to straining, one thing, or constipation itself may be due to some intraluminal pathology, which can become big in size. Constipation, some colonic tumors, which can become big in size. It can cause the pressure on the iliac veins on one side, possible. Okay,
then dialysis for AV malformations, we ask the history. Sir.
Yes. So valvular problem is common in size. Yes.
Then previous surgery for varicose vein, because recurrence is more common.
Good.
So we ask, sir.
Okay. In our boy, he's a 20-year-old only. No occupational implications are likely to be for this small fellow, no?
Yes, sir.
What is the most likely etiology here?
Primary, so it could be familial.
Yes. Very good. So some connective tissue disorder. Yes, possible. You should keep it at the back of your mind. In a very young individual without any background occupational implications, the person is developing, means you should immediately think of some connective tissue disorder leading to weakness of the valves. Possible. You should keep it in mind. Okay, right.
Congenital incompetence also could be there.
Yes, ma'am. Okay. That you should, before giving your final diagnosis, you should carry this out in your mind throughout. Okay. Next slide.
Then past history, no similar complaints in the past, not a known case of diabetes, hypertension, asthma, TB, diabetes, no history of any surgery in the past, no history of surgery for varicose.
Right.
Yes, sir. Treatment history, he has been using compression stockings for the past 5 years.
Okay. Yes.
Personal history, the patient consumes non-vegetarian diet, not a smoker, not alcoholic, bowel and bladder habits are normal, appetite is good and sleep is normal.
Okay.
Family history, no similar complaints in the family.
Yes.
Summary: a 20-year-old male came with complaints of cervical torus occurrence in his left lower limb since 5 years, which increase in size on standing and reliefs on taking rest, associated with intermittent dilating pain. Some history I would like to examine the great saphenous veins.
Hmm. Yes. Okay. For suspected varicosity, you can add. Hmm? Yes. So before we move on to examination, we should have an idea of what are all the classification of varicose veins, because your examination will obviously reveal something associated with that, right? So you can
Yes.
tell what is the broad classification of varicose veins?
A great
Etiology,
saphenous varicosity and short
etiology,
saphenous,
etiology wise.
primary and secondary, sir.
Yes, primary due to
Congenital incompetence or absence of valves.
okay, a valvular condition and congenital
Weakness of,
weakness due to connective tissue disorders. Okay,
yes,
right,
yes, sir.
right. Then secondary,
Secondary due to occupational uh, relevance, then recurrent thrombophlebitis or obstruction due to venous return,
okay,
pregnancy.
yes. So intra-abdominal conditions which result in decreased venous return leading to varicosities, increased exertion also secondary to thrombophlebitis may also be a reason, and uh, abnormal arteriovenous anastomosis may also lead to varicosities. Okay, right.
Yes, sir.
Come to examination. So when you summarize at this stage, you always tell, I want to examine the lower limb for possible varicose veins. Huh?
Okay, sir. Okay, sir.
Great saphenous you can commit only after doing the examination. Okay,
Okay,
the
sir.
patient is not telling particularly over one place, it is not dependable, but I would like to examine the left leg or for possible
Varicose.
varicose veins. Yes,
Yes, sir.
examination. Come.
Sir, shall I come to local examination, sir?
Hmm. Yes, nothing contributory in general, you can come to
Nothing.
local. Yes.
Patient is examined in standing position. Expose the position from umbilicus to the
Hmm.
toe. Instruction: attitude of the limb is normal, no deformity. Localized multiple dilated veins present in his left lower limb, left foot in front of the medial malleolus in the first intermetatarsal space on the dorsum of the foot. Second, upper part of medial aspect of leg. And third one, medial aspect of left thigh just above the knee.
Okay.
Skin color and texture appears
Gauri, I
normal.
would like to
No.
stop you at one second here, because if you come in the past when we are conducting classes in person, we used to ask you directly what are the things you will carry when you want to examine a varicose vein patient.
Torn. Torn.
Apart from your regular things like torch, your illuminoscope, stethoscope, okay,
Yes.
what are the things you are expected to carry? Because during your examination, actually, it may be conducted without
Inch
this
tape, sir.
virtual test. Yes, inch tape. Then what? Varicose vein examine பண்ண ஒரு பேஷண்ட் போனா கையில என்னன்னு எடுத்துமோ. Basic some surgical things are there. You should not come without that. Okay. When you come for surgical exam, this for a good sake I am telling. You should always carry a torch. You should carry an illuminoscope. You know what is an illuminoscope? Yeah? You can roll a X-ray sheet and
X-ray sheet.
plaster it. It is an opaque thing for seeing Transillumination. You should carry it invariably for examination. You should carry. Even for classes, we insist, but none of you bring it. We are a bit legible, so we leave it. But in exams, that might not be the case. The external examiners may be very particular about it sometimes. Right? Sorry, adala regular inch tape, knee hammer. Sometimes that may be needed. For varicose vein examination, what else you need? Tourniquet சொல்ல மாட்டியா?
Sir?
Tourniquet சொல்ல மாட்டியா?
அதான் சார் ஃபர்ஸ்ட் சொன்னேன்.
என்ன சொன்ன? Tourniquet. Okay, how many you will carry?
4, sir.
Okay, right. Then it is also better you carry a crepe bandage or a elastic roller bandage you carry. Okay.
Yes, sir.
You should make sure you ask the postgraduates or your senior people about the bandage, elastic crepe bandage. So, that's also better you carry. Okay. Suppose someone, even I may ask you to demonstrate Pratt's test. Pratt's test எப்படின்னா அப்புறம் bandage எடுக்க வேண்டியிருக்கும். Right? You should carry these two things essentially. Yes. Okay. On inspection, you are told. Next.
Skin color and texture appears normal. No ulcers, scars, stretch marks. No loss of hair, dryness of skin, brittle nails, atrophic blanches, loss of subcutaneous fat. No saphina varix, and the right lower limb appears to be normal.
What is saphina varix?
Large groin vein adjacent to the saphenofemoral junction, which disappears on lying down. So.
Right. It's an varicosity in the saphenofemoral junction. Okay.
It imparts an impulse on coughing.
Coughing. Okay. So here, so far, what is the territory involved?
Sir, I did not get, sir.
What is the territory of the leg which is involved?
Medial aspect.
Yes. So broadly, there are only two territories with regard to varicose vein. One is the medial territory, other is the posterior zonal territory, whatever you call it. So by gross examination, if the medial aspect is predominantly involved, medial territory, then immediately you should think of long saphenous varicosities. If posterior zone or posterior territory is involved by varicosities, then immediately your thinking should be about varicosity of the short saphenous vein. Okay, proceed.
Palpation, no local rise of temperature and no tenderness. All inspective findings are confirmed. No thickening of veins and no thickening of the skin.
Okay. Next.
Brody Trendelenburg test.
So special test for varicosities. Okay.
Positive for saphenofemoral junction and perforator incompetence. Trendelenburg test 1, rapid filling from above downwards.
You would like to split it and tell?
How should I say?
What are the types of Brody Trendelenburgs?
2 tests are there. So Trendelenburg test 1 and Trendelenburg test 2.
How will you do test Brody Trendelenburg type 1?
One, vein is emptied by elevating the limb. Then tourniquet is tied just below the saphenofemoral junction. Then we ask the patient to stand.
How will you look at the saphenofemoral junction?
It is 3.75 centimeter lateral and below to the pubic tubercle.
Yes. Okay. You will tie a tourniquet below the saphenofemoral junction.
Then patient is asked to stand.
Yes.
Then the tourniquet is removed. Rapid filling occurs from above. It signifies the saphenofemoral incompetence.
Yes. The next one.
Test 2, same thing, vein is emptied, then the tourniquet is tied below the saphenofemoral junction, then patient is asked to stand, but tourniquet is not released.
Good.
Then filling of blood from below upwards, so that signifies perforator incompetency.
Yes. Here are the words which are to be carefully put are the rapid filling from above downwards, she has correctly told, and gradual filling from below upwards. Okay. The first one is suggestive of saphenofemoral
Incompetence,
incompetence. Second one is
perforator incompetence.
perforator incompetence. Okay.
uh, Morris's cough impulse test. Here, expansal cough impulse felt over the
Preferably, you should tell the three tunicators or multiple tunicators next, very next. By body, you are differentiating between saphenofemoral and perforator. Very next, you should say which perforator. That is reasonable. Okay. So always do the three tunicators immediately after Brody Trendelenburg's test. Yes.
Yes, sir. Tourniquet test, positive indicating incompetence of above knee, below knee, and lower leg perforators. Dot Boyd and Coffins.
Okay.
Uh,
எல்லாமே இன்காம்பிட்டண்டா?
yes, sir.
Okay. So the clue here, sometimes they will ask you in depth about how you did 3 tourniquet. So you should ask the patient to lie down, elevate the limb, empty the veins, locate the saphenofemoral junction, put a tourniquet below the saphenofemoral junction. Okay. So this tourniquet should not be removed throughout the test, because if you remove it, you are opening up the saphenofemoral junction. That should not be done. Now your aim is which perforator is at fault. That you should find out. Okay. What are the named perforators or common perforators you know of?
Lower leg ankle perforator from below
Yes.
down. Ankle perforator, then lower leg perforator of Cockett, then gastrocnemius perforator of Boyd, mid-thigh perforator, and Hunter's perforator in the thigh.
Okay, so you hold the uppermost tourniquet and ask the patient to stand up and see the column in between two perforators first. I mean tourniquets first. If something is one of those perforators in between two tourniquets is incompetent, then the column of that vein will slowly fill up from below downwards. Okay. Suppose if one column there is no incompetence, it will not fill up. But you remove the tourniquet above that column. If that column of vein which is above that is incompetent, it will come and fill it up. So without removing any of the tourniquet, you should first see if by default any of the column is filling up. Thereby you can come to one conclusion, and after that, by removing one by one, you can see if any of that column is the involved perforators are at fault. So two types. The tourniquet at the saphenofemoral junction should not be removed at any cost. First, the lower tourniquets you should observe before removing them. There is one possibility of finding out the faulty perforator at this stage. If it is not found, then you can remove one by one and find out. Okay. So two stages are there. Yes. Next.
So suppose if the lower perforator we remove, then we see above that we see the filling of veins. What does it indicate, sir?
So we'll imagine without removing any of the perforators, between the first and second one, if there is slow filling, you will see that Hunterian perforator is incompetent. Okay. This is without tourniquet removing, I am telling.
Yes.
The column between above knee perforator and below knee perforator, if it is filling up, then you assume that above knee perforators are incompetent. Then the column of the vein below the below knee perforators and the ankle, if it is becoming prominent, then you see the Cockett's perforator are incompetent. That is one stage. Okay. Now, if you remove the above knee perforators, the segment between second and third tunicate, if it was empty, and you remove the middle tunicate and it fills up suddenly, then you assume that the above knee perforators are not incompetent, but the mid thigh perforators are incompetent. Okay, so which was not prominent becoming prominent is due to a upper segment varicosity. Right? So similarly, if the lower segment is not filling up, you remove the below knee perforator. All of a sudden it is becoming prominent, then it is coming from the below knee perforators into the Cockett's. Okay, like that you should, if it is not present and coming out on release of one tunicate, then it is from a segment which is from above. Okay, right? Yes.
Yes, sir. Then Perthes test negative, modified Perthes test varicosity shrink,
Okay.
Schwartz test positive,
That's,
Pratt's
is
test.
that how you interpret Perthes? How do you interpret Perthes?
I mean, how the procedure, sir?
Yes, what is the result? How do you tell the result of test? Perthes, what is Perthes and what is modified Perthes?
Pain occurs in Perthes test, sir, in the calf.
Shrinking of varicosities you see in Perthes?
Modified Perthes, sir.
Okay.
Superficial veins become more prominent in modified Perthes if DVT is present, sir.
What is the method you use in both? You use a elastic bandage.
Elastic bandage is used in Perthes, and modified Perthes we use only tourniquet, sir.
Yes, that's what I wanted you to tell. Okay, modified Perthes only couldn't understand the levels and filling up of columns in multiple. Okay, I'll come back to that later. Modified Perthes test. Okay, right. Then
Schwartz test positive, sir.
okay, when is it negative? How do you do Schwartz test?
In the standing position, the great saphenous vein in the leg is capped, sir. Lower part of the great saphenous vein. So if impulse is felt at the saphenous femoral junction, then it signifies valvular incompetence.
Okay, then Pratt's test.
Pratt's test blowout seen at above knee, below knee, and lower leg perforator sites.
So for Pratt's test, you ask the patient to lie down, raise the limb, and start applying a elastic bandage from distal to proximal up to the groin. Okay, then you tie a tourniquet and start undoing it. So by the first bandaging, you are emptying all the superficial veins into the deep veins. Okay.
Yes, sir.
And on applying a tourniquet, the main saphenofemoral junction is cut off. So when you undo it, the reverse happens. From deep veins, it comes to the superficial vein, obviously through the perforators. Then those blowouts becomes prominent. Okay, so undoing. We even say you will have to reverse bandage it. You will have to put a bandage, undo it, and start bandaging it from groin to foot. That will even more make the blowouts very prominent. Okay, right. Then
Fegan's method, depressions felt at above knee, below knee, and lower leg perforator sites, sir.
In
Yes.
Fegan's test, on standing, the site where the perforators enter the deep fascia bulges. So we mark this spot, sir. On lying down, it appears as depressions in the deep fascia that confirms the perforator site, sir.
Okay.
Then
Right.
hemosis and Bowman signs are negative, sir.
Okay. That is dorsiflexion, you mean?
Dorsiflexion of
That is
foot and the extension of the knee.
interpretation.
Uh, Pain in the calf signifies DVT, sir.
Okay. Right.
Percussion, Schwarz sign positive. On auscultation, no murmurs heard, no palpable regional lymph nodes present. All peripheral arterial pulses are felt. Right lower limb is normal.
Okay.
Systemic examination, CVS
Yes.
S1 S2 heard, no murmurs. RS normal vesicular breath sounds heard, no added sounds. Uh, CNS, no focal neurological deficit. Per abdomen, no distension, no palpable mass, no organomegaly. All sounds are heard.
Okay.
Summary, a 20-year-old
Yes.
male with complaints of multiple tortuous swellings in his left lower limb since 5 years, which increase in size and standing and release on taking rest associated with intermittent dilation. On examination, localized multiple dilated veins present in his left lower limb, left foot in front of the medial malleolus in the first intermetatarsal space on the dorsum of the foot, upper part of medial aspect of leg, medial aspect of left thigh just above the knee. On performing various tests, there was saphenofemoral incompetence and perforator incompetence at 3 levels.
Okay.
Provisional diagnosis, varicose vein in the left leg involving great saphenous vein, saphenofemoral junction incompetence, and dots, void, and pockets perforators incompetence of primary etiology. See,
Okay.
classification, CEAP classification, C2, EP, ASP, TR without complications.
Why do you say C2?
It is varicose vein more than 3 diameters.
That is a definition of varicosity.
Yes.
What are the other prominent veins possible apart from varicosity? When do you call a distant vein a varicosity? More than?
When it is present
More than?
subcutaneous.
Yes, subcutaneous and more than 3 dia.
Yes, sir. Yes, sir.
It is called varicosities. If it is subcutaneous and less than 3 dia, what is it called?
If it is 1 to 3 millimeter, it is reticular vein, sir. If it is less than 1, it is thread vein, sir.
Okay. So thread veins are mostly in dermal area, not subdermal or subcutaneous. Understand that? Okay. But reticular veins can be beneath the dermis. So location you should understand. Okay. And varicose veins are obviously subcutaneously situated. So C2 is only varicose. It is without edema or pigmentation or ulceration. That's why I am classifying it as C2 issue 10. Okay?
It's
Right. So E is primary pathology. Okay?
primary pathology, sir.
Right. ASP?
Anatomy, superficial system and perforators are.
Yes. Okay. Then
And
primary.
PR is a
It's primary.
reflex.
Okay. Right. With reflex. So without complication. What are the complications you would like to look for in a varicose vein?
Deep vein thrombosis, hemorrhage, sir.
You are going to all rare complications first.
So venous ulcers.
Yes. Skin changes leading to ulceration. See, from mild to moderate, you should always tell. Okay. How does skin changes occur in varicose veins?
Because of chronic venous hypertension, RBC lysis occurs, hemosiderin is released. It causes pigmentation and dermatitis. Uh, then capillary endothelial damage will occur. This will prevent exchange of nutrients. There will be severe anoxia, which will cause venous ulcerations.
Okay. From there on, so your complications you should always tell in such a way. Okay, from mild to moderate. So reflex, venous hypertension, then the RBC exudate, and the release of abnormal hemosiderin, then the skin changes, then your capillary endothelial damage, then anoxia, ulceration. Then after ulcers, what will happen, ma? What are the other possibilities there? That is one of the complications, right? Okay.
Lipodermatosclerosis.
Number?
Lipodermatosclerosis.
Yes.
There will be thickening and induration of the skin due to venous disease.
Okay. That is other form of lipodermatosclerosis.
Then
An ulceration has occurred. What it can do?
Sir, I didn't get.
Yes. Somebody is online.
Sir?
Yes. An ulcer can inwards and cause osteomyelitis of the underlying bones.
Yes, sir.
A long-standing ulcer can lead to Marjolin's ulcer. இதெல்லாம் skin ulcer and ulcer-related complications. Okay.
Yes, sir.
Skin changes right from eczema, dermatitis, ulceration, osteomyelitis, Marjolin's ulcer. Okay. Apart from skin ulcerations, now you tell as you told. Periosteitis, tibia. Okay. Tibia or any bone which is underlying it. Even we have seen osteomyelitis of the metatarsals. So it is lying over the medial malleus or perossum. We have seen cases of osteomyelitis involving the metatarsal bones also. So underlying bone becomes periosteitis that may eventually lead on to osteomyelitis itself. Okay,
then ankylosis.
Deformities, talipes deformities, Equinox says. Then what you told before.
Thrombophlebitis can also occur, sir, as a complication.
What?
Thrombophlebitis.
Exactly. So ulcer and ulcer-related complications you told first. Then you should tell about thrombophlebitis. Yes.
Then deep thrombosis.
Deep vein thrombosis. The imminent danger of pulmonary embolism is there, but they say it is only occurring around 3 or 4% of the individuals only. It is not very common as we fear. Okay.
Yes, sir.
And a very large varicosities with thinned out skin over it can bleed. Right?
Yes,
bleeding
sir.
from the varices. So you should classify it and have it done. So these complications can occur. Okay. What will you do for the patient?
Specific investigation, Doppler ultrasound and duplex USG, sir.
Yes. What will you look for in duplex? What are the things you would like to?
We look for the venous lumen, then flow of the blood, venous flow of blood. Then reflex we see, sir. When we if it is an incompetent vein, it looks as a red color, sir.
Okay. What are the regions you would like to ask the surgeon? What will you be interested in interpreting?
Images of the vein.
Say by reading a duplex USG, as a surgeon, I would like to see the grade of varicosities they will give. Number 1, whether there is saphenofemoral incompetence is there, confirm it. Number 2 is perforator incompetence. Which perforator is involved? I would like to see. That is very, very important. No.
Yes, sir.
And last, before that, I would like to do calcification of veins. What other thing you would like to see? Sometimes I send back I send the patient for duplex ESG. He comes back with the report. I am not satisfied. I will send him back. Sometimes they don't mention about deep vein thrombosis. It is one thing which you should essentially look for. Okay, va? So, example, duplex la enna popping pona. I would like to confirm the varicosities. Number 1. I would like to see which venous varicosity is there. Number 2. Number 3, I would like to confirm the saphenofemoral junction incompetence. Then I would like to see which of the perforator is incompetent. Then I would like to look for presence or absence of DVT. 5 things you will have to observe in duplex ESG. You should tell it in the exam. What you will feel now is that I know all these things, sir. You will tell. That's what, no, Gauri?
Yes.
But it has to come. Okay.
Point wise, sir.
You'll have to tell. That's why I'm telling you. You know all these things, but in exam, how to put it, I am telling you. Okay,
sir,
va?
sir.
I have thyroid I have taught you know what are the findings in USG. Half a but you should put it in an orderly fashion. First, I would like to confirm thyromegaly. I would like to see whether it is a solitary nodule or a multinodular and placement of nodules. Then I will see what is the nature of the nodule, whether it is solid or cystic. Then I would like to see the nodes. Like that orderly pattern I am telling you, that's all. In duplex ESG, I will first confirm varicosities. I look which venous system is involved. I look for SFJ incompetence. I look for any perforator incompetence. What is the perforator actually involved? I look for absence or presence of DVT. So you know now 5 things you will have to tell it in exam. Bit by bit, all of you know that. But in exam, you are expected to put them in an orderly fashion in an allotted time. You should not miss out anything. So this class is meant for teaching you how to speak out in exam. All of you have read, I know you have gone time and again, you have gone through the textbooks. But as examiners, we want you to speak how we want to speak in the exams only. We want to train you. Okay, right. So you should answer in such a way. Right, ma? Okay.
Yes,
any other investigations?
Doppler ultrasounds.
Okay. Investigation of other systems? Yes.
Routine investigations.
Just skip that. Go to the next slide.
And treatments.
Trendelenburg surgery for
Somewhere
saphenofemoral.
around the abdomen you are told?
No, sir.
Why? Routine panna venama? You should also tell ultrasound. It's a very simple but important investigation. You should tell about ultrasonogram of the abdomen. And incidentally, before finishing the examination, you should quickly tell about the pulsations in the exterior of the limbs. Also, you should tell. I forgot to catch you there. Right? Examination of the examination of peripheral pulses you should tell quickly because arterial and venous are interrelated. Right? Okay. Treatment.
Trendelenburg surgery for saphenofemoral incompetence and subfacial ligation of pocket, void, and dorsal.
Straight away.
That's right. Yes.
Suppose one of our close relative family member is having such varicosity.
No, sir.
Okay. Of course, here are no complications. You should always begin like for treatment, I would like to give the option of choosing the minimal procedures first. Okay. Obviously, we also want that, no? Okay. Right. So treatment is of two types, sir. You can tell. Okay.
Yes, sir.
Minimally invasive treatment modalities and surgical.
Yes, sir.
After informing the patient about the advantages of both, if the patient is choosy, I will prefer for minimal treatment first. Okay. What are they?
Sclerotherapy.
Yes. Then, what are the sclerotherapies?
Sodium tetrado.
One is non-injectable interventions and injectable interventions. Okay. So, minimally invasive, I would like to offer endovascular laser ablation, endovenous laser ablation, endovenous infrared ablation. Okay, as the first choice. They are being familiarized nowadays, and I will also consider the option of giving sclerosant through injectables. Okay, sodium tetrahydrosyl sulfate and sodium morphoate and ethylamine oleate. All these things are possible. Three things you remember. But
Yes, sir.
the most often used is sodium tetrahydrosyl sulfate. When you mix it up with air, it becomes foam sclerotherapy. Okay, so and you should tell all these things first. Right? அப்போ எப்படி ஆன்சர் பண்ணணும்? How will you treat the patient? Means, sir, the treatment can be minimally invasive type or surgical, sir. The patient is preferring for minimally invasive, which is most often the case. I will go on for endovenous non-injectable interventions like endovenous laser ablation, endovenous infrared ablation, and injectable interventions like endovenous foam sclerotherapy or other injectables. Okay, அவ்வளவுதான். This is the broad classification of minimally invasive interventions. Of course, some rare things are there. Cryotherapy இருக்கு. Injecting cold water into the thing, or even hot water leading to endothelial damage and fibrosis. You just go ahead and read about this, but the classification runs like this. Okay, minimally invasive surgery, minimally invasive non-injectable endovenous interventions, and injectable endovenous interventions, then surgeries. Okay,
Sir.
you will carry on this classification.
Yes, sir.
Yes. Next, surgery wise, you tell me.
Trendelenburg surgery for saphenofemoral incompetence, sir.
Yes.
Here we do two things: saphenofemoral flush ligation and
Yes.
ligation of the proximal 5 tributaries, sir.
Okay. What is the importance of necessity to tie the tributaries?
So that recurrence will not occur.
Okay. Right. So, if the ligation is not high enough, you just imagine this is the end of the long saphenous vein. The tributaries come here. If you are going to ligate it there, mostly it won't be any problematic. Okay. So, if you leave the tributaries, then after ligation, if the tributaries are connected, the veins may come from the peripheral thing into the already existing vein and cause varicosities. So, individual identification of the tributaries of great saphenous vein ligation and flush ligation will only lead to non-recurrent state. Okay, so flush ligation of great saphenous vein and identification and ligation of each of the identifiable tributaries. Okay, right. Then
Subfacial ligation of pocket, void, and dot perforators, sir.
what is stripping? You would like to choose that? or you don't want?
Stripping. This is below knee also, so it may damage the nerve. So stripping not preferred.
You can do stripping at a higher level. So
Yes, sir.
it's an option. Okay. So
Sir.
the options are as follows. One is Trendelenburg surgery followed by stripping. Okay. You flush ligate, identify the things, and put a stripper and remove it. That is one type. When you do this, there is no question of identifying the perforators. You understand? Okay.
Yes.
And when you do stripping of the vein, you do it up to the mid leg level, below knee only. You need not go beyond the middle of the leg because of fear of injuring the saphenous nerve. So medial malleolus வரைக்கும் vein விட்டு strip பண்ணக்கூடாது. It is not indicated now. Okay. So mostly this thing will address the problem. That is a stripping. So you can do a number one option is you can do a flesh ligation with stripping. That is one. Or second option is you can do a flesh ligation. Do not strip the vein. Individually go there and do a subfacial ligation of all perforators which are incompetent. So உன்னோட இதுல வந்து டூப்ளெக்ஸ் ஸ்கேன்ல எந்தெந்த பெர்ஃபரேட்டர் இன்காம்பிடென்ட் அதெல்லாம் போய் ஒன்னா சப்ஃபேஷியல் லைகேஷன் பண்ணலாம். That is second option. Okay. Third option is fortunately if your duplex says that perforators are perfectly normal, only the saphenofemoral junction is incompetent, then it is enough if you stop with
Flush ligation.
Flush ligation and the ligation of tributaries and come back. Okay.
Yes, sir.
This is the one. And the reverse case where sometimes saphenofemoral junction is competent on only the perforators are incompetent, you will do an isolated subfacial ligation. Okay, va?
Yes, sir.
And apart from this, in addition to this, there may be some non-anatomical varicosities. நம்ம லைன் ஒரு லாங் saphenous vein அதுல இருந்து தனியா சின்ன சின்ன ப்ளோட்ஸ் இருக்கும். non-anatomical varicositiesனு பேரு. அதை எப்படி டேக்கிள் பண்ணுவோம்னா it is called avulsion phlebectomy. Okay, it is called avulsion phlebectomy, where you put an incision over that non-anatomical varicosities and twist it and excise it away. Okay, so the treatment options: number one, Trendelenburgs with stripping. Number two, Trendelenburgs with
Subfacial
ligation when there is associated incompetence of the perforators. Number three is only Trendelenburgs if the perforators are competent. Number four is isolated subfacial ligation if only the perforators are at fault. Number fifth is avulsion phlebectomy, or you call it stab phlebectomy. Stab, S-T-A-B. Okay, you put a stab incision, dissect out, take the non-anatomical varicosities and twist them and apply clamps and remove them. That is called avulsion phlebectomy or stab phlebectomy. Okay, so you have these 5 options in mind. When to do all these things, you should decide. Okay. Regarding stripping, I want to say one thing. When will you not to do stripping? There is an advantage in not stripping of the vein. What is it? Can the vein be useful in any way in future? Long saphenous vein, the precious one. Gauri, tungya?
Listen.
Long saphenous vein is very precious, I told you. Yes.
Bypass surgery, sir.
Yes, exactly. So it is, if it is not too tortuous and healthy, it is a important structure for CABG in future. So your patient is a heart patient some serious problems are there. Even then, if it is not very much damaged, I think without stripping, you should preserve the long saphenous vein, because most of the cases, if it is multiple blocks, they choose to do CABG. Okay, so you can tell I will not strip the vein, sir, because I would like to preserve it for probable or possible CABG in the future. You can tell. Okay, right. Then the management of complications also you should tell. Ulcer management, we have already discussed about an ulcer, you should tell, but these 5 options you should keep it in mind. So I would like to come back to Jemima. She asked one question. She cannot understand the levels of filling up of multiple tonic. I will just explain that now. Regarding this, the varicose veins, not much of this, but the theorists may sometimes ask, okay, fibrin cuff and the white cell trap theory, all those things they may ask you. You should remember. So, multiple tunicate test. See, our Gauri has told the patient is having SFJ incompetence and perforator incompetence, right? Jemima, you can unmute yourself and come. You can ask some questions then and there if you have any doubt. Right? So Gauri has told there is saphenofemoral incompetence and perforator incompetence. Now our purpose is to identify which of the perforator is at fault. So we club the perforators into 3 regions. One is between the first tunicate and the second tunicate. That implies the adductor canal perforator or mid-thigh perforator. The second perforators are combined one, namely the Dodds and Boyds, which are lying between the second tunicate and third tunicate. And the perforators below the third tunicate are the Cockett's. Okay. Now, because she has told there is some perforator incompetence, without removing any of the tunicate, you ask the patient to, with all 3 tunicate in place, you ask the patient to stand and perhaps make the patient walk a bit and sit. See if any of this, one of these things should obviously fill because of incompetence. So without removing, you can see if one thing is filled up. For example, the above knee and below knee, between the 2 things, if it is becoming prominent, then you assume that it is incompetent. Now you go ahead and remove the lowermost tunicate and see the prominence there will immediately start filling up from above behind into the lowermost one. In that case, the Cockett's perforator are not incompetent, only the Boyd and Dodd are incompetent. You should decide. On the contrary, you go to the upper one. If the second thing is not filled up, only the mid-thigh perforator is becoming prominent, the second component is empty, then you wait for some time and remove the second tunicate and see the prominence which was absent in the second thing will become slowly, because of the flow back of the incompetent veins from the upper segment will come and fill it up. Which was not prominent will become prominent. That means the perforators in that segment is not incompetent. The perforators in the above compartment are incompetent. So kindly remember 3 tunicate first without removing any of the tunicates you should judge, number 1, and then you remove the tunicate and see if there is fresh filling up. Then it indicates that the part above that tunicate is having incompetent perforators. That is the simplest way to understand. You start releasing it from below upwards. Okay? Jemima. புரியுதா? ஸோ 3 tunicate போட்டு எல்லாத்தையுமே அவுக்காம ஒரு தடவை பார்க்கணும். அதுக்கப்புறம் ஸ்டார்ட் removing it from below upwards and see which was not prominent becoming prominent means then the problem is in the segment which is above it. Okay. So you go and again think over it and the physics behind it. That's all. Okay. And these are all the practical questions which will be asked. I told you it's not very elaborate. And if the varicose vein patients comes with an active ulceration, then you should mention local area X-ray to be told to rule out osteomyelitis. Then the complications of Marjolin's ulcer they will ask you, okay, and skin grafting, all things will come. What we have dealt in chronic ulcer, you should remember and tell, okay, right? You'll wind up.
Sir, excuse me, sir.
Any doubt?
Sir, I have a doubt, sir.
Please come.
Sir, varicose vein is already a diseased vein, sir. So we
Yes.
still prefer it for CABG, sir.
Yes, because the vein which you are putting, there is some weakening of the wall. It is already because of venous hypertension. But what they say is when you connect it to an artery, a process called arterialization of the vein occurs. The vein which was initially thin-walled like a vein, out of necessity will become thicker and become an artery-like vessel. Ishadana Ketama?
Yes, sir. Yes, sir.
So this is one process which you should always remember. CABG vein vacha, and the vein due to repeated arterial flow, it will become arterialized. This is a process which is happening in case of using a vein for arterial purpose. Okay. So
yes, sir. Thank you, sir.
of course, arterialization of the vein. Vein or a thin wall structure is different from arteries. It transforms itself and acquires the capabilities or the anatomical structure of an artery as such. That is called arterialization of the vein. Even if it is a thin-walled vein, you use it, it will become thick and become like an artery. That is arterialization of vein. Okay? Is it clear?
Yes, sir. Understood, sir.
Yes.
Thank you, sir.
Only thing is, when varicose vein is caused hemorrhage and irreparable damage, you should not use it. But an intact vein, though it is thinned out, it can be used for CABG. Okay, ma? Right.
Yes, sir. Thank you, sir.
Welcome. You'll wind up. So we have discussed hydrocele in our discussion. It is one of the important things which you can impress nicely if you learn to present. Hydrocele discuss pannitama. The rep come out. Who is that girl?
No,
Kavyava. Kartika. On Thursday, what class you want?
GO, sir. Gastric outlet obstruction. Gastric outlet obstruction.
We haven't discussed?
No, sir, we didn't, sir.
Okay. You want a benign GO or a GO due to CS stomach?
Sir, I'll ask the presenter, sir.
Yes. She can present she or he. பசங்களை யாரையும் பார்க்க முடியல. Who is the boys in the group? Kaushik. Kaushik வந்திருக்கான்ல?
Yes, sir. Kaushik Prithviraj.
He's not answering. He's still muted question.
Sir?
You are there?
Sir?
I want to hear some boys' voice.
Sir,
okay. One of you will present gastric outlet obstruction. Either benign or malignant is okay, but we will discuss both when we come to the discussion part, right?
Okay, sir.
So if it is necessary and the GO has not been discussed, you can take a guess. It will be interesting. Sometime if you want an obstructive jaundice, you can present, but UG's obstructive jaundice usually they don't keep. Okay, so you discuss among yourselves and see what system you want to be discussed quickly. I also tell you, if you are having any exams, please don't trouble yourself. This I am doing because I think that you are free and you need to be practicing more. That's right. Okay. சரி, நமக்கு வேலை இருக்கு, சார் என்ன நினைச்சிட போறாருன்னு நினைக்காதீங்க. If you have any exams or commitments, no problem. You can be transparent and tell me the problem. Okay? This is to provide you with an opportunity to train yourself in presenting and discussing. Okay? Right.
Yes, sir.
Thank you. You decide and tell me one day prayer. Okay? Goodbye,
sir.
everybody.
Yes, sir.
Kaushik,
Thank you, sir.
goodbye.
Bye.
Thank you, sir.